afternoon, everyone. My name is Martine Franckena. I'm a radiation oncologist at Erasmus MC in Rotterdam, and I'm going to show you our data on dose response in patients treated with radiation and hyperthermia for locally advanced cervix cancer. And I'm going to show you that both temperature and energy distribution matter. It's mainly work done by one of our residents, Michiel Kroeze, and one of our PhD students, Tim Mulder. I think by now you all know the concept of thermal dose, and that a higher dose probably represents a better effect, and that the dose is dependent both on time and on temperature. So then an optimized dose could consist of an increase in temperature that you can obtain either by improving your targeting or improving your technique, or increase your treatment time. But that's not something our patients will appreciate when we speak about deep hyperthermia. There are two prospective trials done to evaluate the concept of higher thermal dose is better clinical outcome. Ellen Jones did a trial in 109 superficial hyperthermia patients with breast cancer, and she saw that indeed patients obtaining a dose of 10 cumulative equivalent minutes of T90 at 43 degrees is indeed better than patients receiving one or less. And there was also a trial done in 120 dog soft tissue sarcomas, where they saw the same kind of effect when comparing 2 to 5 of these cumulative equivalent minutes to 20 to 50. But of course, dogs also have the advantage that you can sedate them while you're treating them, and which is not something that we generally do in adult patients. On deep hyperthermia, there are several retrospective series that also confirm the same effect, that a higher dose represents a better clinical outcome, where varying dose measures were used, but the most prevalent one is the cumulative equivalent minutes. In our analysis of 420 patients, we suggested an alternative to these cumulative equivalent minutes by means of the T-rise. The problem with these cumulative equivalent minutes is that although there is a strong biological rationale, it only accounts for direct cellular effects of hyperthermia, while we know that the efficacy is due to much more than only these direct cellular effects. And it's also based on the T90, which makes it very vulnerable to outliers. Our T-rise was mainly a sort of counter motion to the importance of the T90, and it's based basically on the average temperature increase obtained for a fixed duration of time. We saw a highly significant correlation in our cohort of 420 patients for both thermal dose measures, although we could not define a threshold for the thermal dose effect, and looking back at the prospective trials, only 9% of our patients we were able to achieve 10 equivalent minutes or more, comparing to the Jones trial, and only one more than 20 comparing to the Thrall trial. And there was also a very large spread in the thermal dose obtained. But in the graphics you can see that in general there is a tendency towards higher dose is more efficacy of the treatment. Of course, since then, in the treatment of cervix cancer, we have entered a new era with the implementation of image-guided brachy, which has greatly improved local control and also overall survival for cervix cancer patients. So we have since then summed up the data of the patients we have treated after the old analysis was done. Since 2005, we treated 270 patients with locally advanced cervix cancer. About 1/3 of those were treated with image-guided brachy, so with state-of-the-art radiation techniques that were introduced in our hospital in 2012. And we sought to see if we could confirm our previously found dose-response relationship in this new cohort of patients, and again look for the influence of hyperthermia dose after the implementation of these new radiation techniques. We had a median follow-up of 52 months, which was 82 months for survivors, and as to be expected, we saw that 5-year local control was substantially improved in the new cohort, 73% compared to 53% in the old cohort, and also the disease-free survival, sorry, that should be 5 years as well, now 63% compared to 45% in the old cohort. Here you see the results of the univariate analysis, where here below you see that if patients have had image-guided brachy, yes or no, very strongly influences local control and survival, but still both TRIs and the cumulative equivalent minutes, they keep their significance, at least for local control and for disease-free survival. It may be important to bear in mind that the patients that are routinely referred for hyperthermia are patients with larger tumors and a counterindication for chemotherapy, so usually they are less fit and older, and they have larger tumors than those treated with chemoradiation. Here you see the thermal dose effect in Kaplan-Meier curves for local control with the TRIs and cumulative equivalent minutes, and you see that that's still very significant in this new patient cohort. The exploratory analysis on the thermal dose effect after the implementation of the new techniques. Please bear in mind that this is not a high number of patients. Only 17 patients received the optimum dose of brachytherapy and the optimum dose of hyperthermia, but then you see that local control and disease-free survival are almost at 100%. But still, for as far as we can say now, this is still important, where even in patients treated with state-of-the-art radiation, a higher dose results in better clinical efficacy. So temperature still matters, and the search for optimized thermal dose can continue. And the way we are doing that in Rotterdam is by investigating the use and the possibilities of MRTI, so non-invasive thermometry using the MRI, in the pelvic region, and we use SAR-based optimization for hyperthermia treatment planning. If we go a little bit beyond the thermal dose effect, and we look at what we know beforehand, because a thermal dose is always something you know after you have treated a patient, which is also always a bit of a pity, because as a doctor I would like to know beforehand if I can heat a patient or not, and how high I should heat a patient. We have introduced hyperthermia treatment planning with SAR-based optimization, so energy-based optimization, in July of 2011, and since then we have treated 205 patients with this. And we have follow-up on local control available for 69 of them. And here you can see the thermal dose measures, cumulative equivalent minutes, and TRIs compared before and after the introduction of treatment planning in our clinic. For the cumulative equivalent minutes, it does not really seem to matter. TRI seems to be a bit increased after the implementation of. Which parameter is used best for optimization? There are a lot of suspects that you can think about. You can look at a ratio between energy in a target and energy in the surroundings, ISO-SAR coverage. The Q target is the total amount of energy deposited, or the mean total power average over steady state. Well, there are a lot of possibilities. We looked in an exploratory analysis which of these energy parameters that you know beforehand predicts outcome, which was difficult as we had outcome available for only half of them. So then we said maybe we should look for energy parameter versus thermal dose, as thermal dose significantly correlates to outcome as a surrogate outcome measure. And we did the analysis for both the TRIs and the cumulative equivalent minutes, and in both cases the target hotspot ratio is the best predictor of thermal dose in these patients. Unfortunately, we have a bit of the same problem that you saw in the older thermal dose analysis, in that the spread is still quite large. That spread is probably due to large variations in patient condition, thermal property variations, measurement uncertainties, and modeling uncertainties. So there's much more work that we can continue with. But the end goal being, as I try to describe, is to go from something that you can know beforehand that predicts clinical outcome. So you can start estimating heatability and know beforehand which patients to treat and not to treat. We've been making small steps in between to try to get there, and I've hoped to show you some of the between steps for now. And I thank you for your attention.
Questions from the floor? I just wanted to check with you. I mean, do you use hypothermia also with the brachytherapy?
In brachytherapy patients, you mean?
Yeah.
Yeah.
I mean, during the brachytherapy sessions.
No, not during.
Okay.
It's during external beam.
So fine. If there are no further questions, then I think